Common medications that you will see in GI disorders: histamine 2 blockers and protein pump inhibitors. Gastroesophageal reflux is a very common occurrence, especially in infants 18 months and under, that you will see. Antibacterials or antibiotics may be required. Steroids if they're having an inflammatory response. Stimulants and laxatives. One that you'll see is antidiarrheals and antiemetics. Very, very strongly urge you, you would urge parents that antidiarrheals that can be bought over the counter should not be given to children. If the diarrhea is so severe that there's a need for that, then they should be evaluated by a practitioner first. So please read the table in your book that goes over medications for gastrointestinal disorders. Be familiar with them. What are risk factors that can cause these? Prematurity. Unfortunately, prematurity can cause a lot of different disorders. Just like chronic lung disease, being premature is a risk factor for that. Gastroesophageal reflux disease is also common occurrence from being premature. So what places the child at risk for dehydration? Diarrhea and vomiting, two of the most common things you will see in an infant, in a toddler child. Both, if fluids are not replaced, can place the child at risk for dehydration. Decreased oral intake. Children are very simple. If they're not hungry, they don't eat. If they don't feel good, they're not going to eat. If they're having diarrhea and vomiting, they're not going to feel good. They're not going to take fluids in. So decreased oral intake also places them at risk. A sustained high fever, as I mentioned in the previous recording, for each degree Celsius the fever is elevated above normal, they lose an additional 7 milliliters per kilogram per 24-hour period of fluids. And children, because their nervous systems are not fully developed, do run very high fevers. They can run high, they can go on suddenly. If a child is in diabetic ketoacidosis, whether they're a child or an adult, this still, because the body is trying to get rid of excess glucose, they lose a lot of fluid, very at risk for dehydration. And then burns, because of that body surface area to body mass. Any kind of a burn where they're going to lose fluid is going to be a large amount and very high risk for dehydration. So what are some acute gastrointestinal disorders? I'm not going to go every single one of them. Your assessments are going to be the same. A lot of your interventions are going to be the same. I'm going to touch on some that you probably are not familiar with because they are common to pediatrics. So in dehydration, what do you look for? There's 3 stages, and there's a chart in your book. Be familiar, know the 3 stages. There's mild, moderate, and severe. Mild and moderate can typically rehydrate with oral solutions. Severe will need an IV for rehydration. But the little diagram here, it shows you the symptoms that you're going to see in dehydration. You're going to want to know these symptoms. What is oliguria? It's decreased urination, dry mucous membranes, decreased level of consciousness, increased heart rate, low blood pressure, sunken fontanelle, no tears. So when rehydrating, be familiar with these as well. Oral hydration to mild to moderate, Pedialyte, Infolite, IV hydration. It goes in stages. You have your initial hydration amount, and then you have maintenance. So be familiar with those. So a quick question, is the following statement true or false? The nurse is caring for a child with diarrhea related to infectious enteritis. The nurse accurately informs the parents that most cases of diarrhea are bacterial in nature, and therapeutic management is usually supportive in nature. So right there, you should pick up that this question is going to be false because you have conflicting information. If you say that the cause is bacterial in nature, but the therapeutic is supportive, then that doesn't match. If it's viral, it's supportive. If it's bacterial, you treat with antibiotics. So most cases of diarrhea are viral. So the answer to this was false. Okay, so the next one that you're probably not familiar with, and it's really kind of fun to try to say, intussusception, is an occurrence that happens in children about 1 to 2 years old. They may present to the emergency room with abdominal pain. They may not have had a bowel movement, or if they have, it's kind of, they call it current jelly-like. It's going to be like a reddish black, and it's going to be gelatinous. But what happens is a portion of the bowel telescopes into the other portion of the bowel. Commonly, it happens because there's a polyp or scarring or something that makes it a weak area to do that. Sometimes these will resolve themselves. If they don't, the child continues to have increasing pain. They'll be brought to the ER for abdominal pain. When they evaluate them, ironically, the means of evaluating and diagnosis is most times the means of treating it. A barium enema, they go in to visualize it, and the barium enema actually pops it back out so that it's no longer telescoped. If that doesn't work and they've diagnosed it, then surgery would be the last option for these children. But do make sure that you look at what you're assessing for, the diffuse abdominal pain, knees to the chest, crying, but the hallmark sign is the current jelly-like stool. So structural anomalies of the gastrointestinal tract. We're going to start with cleft palate. So it's actually, there's two types. There's the cleft lip and the cleft palate. Now, commonly, you can have a cleft lip, but an intact palate, and that is much better. But you can also have the cleft palate, and because the lip is intact, it may not be picked up right away. It may not be as easily visualized. Or you'll see children who have the cleft lip through the palate. So with these children, a couple things are high priority with them. So first, nutrition. How are they going to nurse? How are they going to get nutrition? So there's many different ways of feeding. There's Haberfield bottles. And your book kind of addresses some of the different types of nipples and nursing. They may be fed with a syringe. It basically matters if they're able to get a good seal on the breast or on the bottle. The other thing to keep in mind is that when children have a cleft lip or cleft palate, they also at risk for other defects or anomalies. They tend to all form at the same time in the embryonic development. So you may see heart defects as well, or ear malformations, or genitourinary abnormality. So you'll see feeding difficulties, maybe altered dentation. These are complications that can occur. Typically, cleft palates are repaired prior to speech formation. So they do try to get them repaired prior to 18 months or 2 years of age. Cleft lips, they'll do much earlier in the child's life, within the first 3 months, so that it can heal and look as normal as possible. It also helps with nutrition. So when these children have had their surgeries, there's some high priority nursing management. You want to make sure that they're not able to touch or reach their face with their little fingers, or they're not able to rub their face against bed linens, parents' shoulders, anything that can agitate or tear a suture line. These are done by cosmetic surgeons. So there's some things you would want to keep in mind. Put them in a supine or sideline position. If you put them prone, they're going to bury their faces into the sheets and work on those sutures. You may have to put arm boards on their little arms. These are considered restraints, so they'll have to be released. They'll have to be documented, monitored, but it prevents them from bending their arm and reaching their face. You want to keep them as calm as you can so that there's not screaming or strenuous crying. Encourage nutrition with nipples and syringes. So another anomaly of the gastrointestinal tract would be a hernia. There's two very common types of hernias that you'll see in pediatrics. That would be an inguinal hernia, and that is located in the groin, or an umbilical hernia. So as long as they're soft and reducible, meaning you can push it back in through the opening, they do not typically receive treatment. They'll be monitored. Umbilical hernias will resolve themselves about 4 years old. An inguinal hernia, if it hasn't resolved itself by about a year of age, then they will look at going in and doing a surgical closure where they put a patch over the opening. One of the things that should be assessed and should be taught to parents is ensuring that it's soft, looking at the color. It should never turn grayish or bluish or hot red, and the temperature should remain similar to the rest of the body. Pyloric stenosis. This is something very common to young infants. These infants will typically report to the emergency room or their doctor's office at about 2 months of age with the report that they're crying, they're so hungry, I feed them, they gobble down the bottle, and then it comes right back up, and it is so forceful, it goes clear across the room. So when you hear that kind of a report, and other than that, the child's been healthy, they had a normal pregnancy, no complications, you start to suspect maybe a pyloric stenosis. And when you palpate the abdomen, you will feel a hard little knot. They call it an olive. And what that is the circular muscle of the pylorus. It's become enlarged, hypertrophied, and it has narrowed the pyloric canal, which prevents the stomach from emptying. So what is happening is the child, the infant, very hungry, gulps down a bottle, but it doesn't pass through the pyloric canal, so it's not absorbed. The baby still gets the messages that it's hungry, it drinks more, but the stomach is full, so it's forcefully ejected. Now, they're fairly easily treated. It is a surgical procedure. They'll go in with a scope, but they do a pyloromyotomy, where they go in and they cut a portion of that sphincter out to allow for easier gastric emptying. So chronic gastrointestinal disorders. These are things that don't have quick fixes. They are not easily taken care of. Read through. The ones I'm going to talk about, though, are gastroesophageal reflux, Hirschsprung. So gastroesophageal reflux, there's a difference between gastroesophageal reflux and gastroesophageal reflux disease. Reflux is common in infants, especially in premature infants. It usually occurs the first year, and it usually will resolve within 12 to 18 months of age. In the instances where it's so severe that it is interfering with eating, weight gain, development, it may be necessary to do a procedure called a Nissen fundoplication, which is where they take a portion of the upper stomach and they wrap it around the base of the esophagus to tighten that sphincter.